Okay, so we're going to go over Chapter 27, Anger, Aggression, and Violence. This begins on page 515 in your textbook. So anger is the emotional response. Usually the person is feeling very threatened or challenged. Aggression is the act, the physical movement, verbal, whatever that may be. So you will see anger and aggression more often on these three types of units: psychiatric units, emergency departments, and geriatric units. And I think we all can understand why, but in our psychiatric units, our patients tend to be pretty unstable mentally, not all of them. So I think it's important to recognize that when you go onto these units, you're not necessarily put into danger, just you need to be more aware that there could be a problem. Emergency departments tend to be very unpredictable and have extra family members involved, so things can escalate very quickly. And then on geriatric units, it's more related to confusion and things like that. So some comorbidities that go with anger and aggression: PTSD, not always, but sometimes. Substance abuse disorders tend to kind of go hand in hand. And anger and aggression tends to coexist with either depression or anxiety, psychosis, and then personality disorders, which we'll talk about in the future. So there are some evidence factors in our biology that we can look at. With the brain, we can see certain brain tumors, Alzheimer's disease, epilepsy, and then traumatic brain injuries tend to cause more issues with anger and aggression. We also see issues if the limbic system is affected, that causing some problems. The prefrontal cortex, or the frontal lobe, does play an important role in aggression, and if we have damage to that area, we typically can see some problems with anger and aggression that the patient didn't have before. And then some are just more predisposed because they have life events that kind of lead up to more opportunity to have anger and aggression. Psychological factors, we can look at the behavioral theory that this is a learned response, that they have seen this happen over and over in their life. Social learning theorists show that children learn this by imitating others. So it's more of that learned response. So application of the nursing process. When we are assessing somebody that has anger and is starting to show aggression, we do have to remember that it can manifest whenever we have increased demands on them. So we may see irritability, frowning, redness of the face. They may be kind of wringing their hands, clenching their fist. So those are some signs that we may see. Some other signs and symptoms are listed in box 27-1, and they don't always precede the violence, but you guys can read those there. Hyperactivity, increased anxiety and tension, verbal abuse, and then when we start to hear them get that loud voice or intense eye contact. And you can see some of these other predictors listed here as well. Trauma-informed care, it is an older concept, but it's kind of come back around. And it does kind of focus on the patient's past experiences with violence and trauma and how they have responded to those and how that plays a role in their life right now. So we could look at some of their past life experiences and see how they have learned to cope from those. And we may need to teach them some new coping mechanisms to deal with their feelings. Self-assessment is our ability to depend on our self-awareness in these situations. It's really easy to become non-therapeutic in an aggressive type situation if you tend to draw away when somebody becomes aggressive. So what you want to do is promote a calm response. You don't want to potentiate anger. You don't want to get into a yelling match with a patient or challenge them in any way during this situation. you want to be in an environment that encourages staff to speak openly about their feelings, that does use humor when appropriate, that has a professional support system, and you want people working with you that have had multiple different types of experiences with their clinical work, so they can bring a lot more to the table. So here's our first question. An adult with paranoia becomes agitated and threatens to assault a staff person. Select the best initial nursing intervention. So do we tell the patient, if you do not calm down, seclusion will be needed? B, address the patient with simple directions and a calming voice. C, help the patient focus by rubbing the patient's shoulders. D, offer the patient a dose of antipsychotic medication. Or E, reorient the patient to the time and place. The correct answer here is B. A, we never want to threaten a patient with seclusion. C, we want to give our patient a good amount of space. We don't want to get that close to them. D is kind of jumping the gun a little bit. E, our patient isn't confused, so they would probably get a little bit more upset if we tried to reorient them. So a new nurse asks a co-worker which patients are most likely to become angry or aggressive. What are some risk factors that can predict? So we can go back and look on that box 27-1 on page 517. Those are some predictors of violence there. The other things that we can look at are listed in the assessment guidelines on page 518. A history of violence is usually the best predictor of future violence. If a patient is delusional, hyperactive, impulsive, or irritable, we could see a higher risk for violence there. We do want to follow up with the patient and ask them if they have the wish or intent to harm, if they have a plan to do this or the means available to carry out the plan. And then there are some demographic risk factors that are listed here. Male gender, age 14 to 24, low socioeconomic status, inadequate support system, and prison time are also some demographic risk factors. So these are our nursing diagnoses that we're going to focus on for our patient with anger and aggression. Many times this anger and aggression results from ineffective coping mechanisms, so unhealthy coping. And table 27-1 in our book on page 519 gives us some signs and symptoms as to why this might be the priority diagnosis for our patient. So signs and symptoms for ineffective coping is difficulty with simple tasks, inability to function at previous level, poor problem solving, poor cognitive function, and verbalization of the inability to cope. And so you can see the outcomes also listed in that table. Stress overload being another nursing diagnosis. These patients have the ability to verbalize their feelings, but they just feel completely overwhelmed. And so some of our outcomes for them would be expressing our feelings constructively, reporting feeling more calm and acceptance, and then the physical symptoms that they may be experiencing are diminished. And then you guys can follow through by looking at the rest of this table for our other types of nursing diagnosis. So what are some ways that this new nurse, because he or she is worried about anger and aggression on the unit, can keep himself or herself safe while at work? So let's look on page 520, and it's that considerations for staff safety. 6 basic considerations to ensure safety. So these are some things that we will want to let the nurse be more aware of. We're not going to be wearing dangly earrings or necklaces because they could grab those and choke or cause injury. So it does need to be removed before you go on to any type of unit, emergency, geriatric, or a psych unit in particular. Making sure that you're not short-staffed is important. Knowing the layout of your unit, where the hazardous things are, where is a safe place to be, You do want to make sure that when you're having a confrontation with a patient that you're not standing directly in front of the patient or in front of the doorway. This is definitely a confrontational stance if you're standing right in front of the patient or in between them and getting out of the room. Stand off to the side, encourage the patient to sit down. You guys get on the same level. That's going to be a lot better for the patient. If our patient begins to escalate, we need to provide some feedback to them. Observing how they're feeling, observing their actions, it may help to de-escalate the situation. And then avoid confrontation with the patient. We don't want to have this big show of support with security guards because that's going to further escalate the problem. We do want to make sure and use what we can to kind of calm things down. If we do a show by force by the security guards, they just need to be available and not within the eye of the patient. Box 27-2 does mention several de-escalation techniques. So these are some things that we use to help calm a patient down. Okay, so implementing our interventions, for psychosocial interventions, we definitely want to stay calm, controlled, open, non-threatening. We want to be honest with them at all times and show that we really do care. We want to maintain a relaxed posture, so we're not going to stand there with our arms crossed, right in front of them. We want our eyes to stay on the same level as the patient, so if we're encouraging them to have a seat, we're not going to stand up over them, we're going to have a seat with them. But allow our patient enough personal space that it doesn't seem intrusive, that we're not so close to them that it feels like we're in their space or in their bubble. Whenever our patient's anger starts to escalate, they tend to lose the ability to process their thoughts. So we're never going to yell. We're always going to continue to model controlled behavior, even though their behavior may be escalating. We do want to use some open-ended questions if we can to help them start talking to us rather than being upset. If we are trying to get them to go into a different room or give them some options as far as where to go from here, we want to give them just two options. We don't want to say, well, what do you want to do? Because they're not going to be able to process those thoughts. So the example in our book says, do you want to go to your room or to the quiet room for a while? So this does give them an option so they feel like they have some autonomy with that decision, but it doesn't give them so many options that they feel like they can't make a decision. We've already talked about our considerations for staff safety. Those were the 6 basic considerations we talked about with our new nurse. Pharmacological interventions for our patient. We could offer a PRN medication, but we're not going to force anything on them. Some of the medications that we use are anti-anxiety agents or antipsychotics during that time. So we're going to assess the need for that PRN medication and offer that. It is up to the patient at this point if they're remaining calm, if they decide to take that or not. Health teaching and promotion, probably the most important thing is for us to maintain that role model appearance, that we are role modeling calm, non-threatening, controlled behaviors. And we want to help educate them on some coping mechanisms after we get through this exacerbation phase. With case management, remember this is a multidisciplinary approach. The whole team is going to be talking about interventions, and the consistency of the team is what is key on helping the patient be successful. If we have certain people on our team that are not following through with their job or their role, then the patient is going to view the whole system as not credible. So we want to make sure that everybody is on board. Teamwork and safety. So it's important to be proactive and not reactive to our patient. We do want to look at the entire milieu of the unit when a patient is having some aggression and is escalating, because this is going to also be upsetting to the other patients. So we want to make sure that not only the patient that's escalating is safe, but also the other patients on the unit. So we will have them actually move away and keep our escalated patient possibly in the same place until we give them some options of where to go. That way it's not affecting as many people. Seclusion and restraints. Seclusion is that involuntary confinement for the patient. Now remember, the goal is never to tell them that they're in trouble, but it's always to promote safety. A restraint can be a physical restraint or a mechanical restraint, a medication, or any type of equipment. And I think we're pretty good on restraints here. But there are some nice reminders for guidelines of mechanical restraints on box 27-3 on page 524 that you might want to review if you don't remember what we talked about in our first unit. And these are the guidelines just listed here on the slide, but this is the same information that you would get in box 27-3. So a patient becomes violent and must be placed in restraints. What questions need to be asked after this incident? And these questions begin on page 523. Questions to be answered include the following. Could we have done anything that would have prevented the violence? Did the team respond as a team? How do staff members feel about this patient? If they're fearful or angry with the patient, it may not be the best situation there. Is there a need for additional staff education regarding how to respond to violent patients? How did the process actually go of restraining them? And if an injury occurred, did we report it? Was it taken care of? And who was injured? Was it the patient? Was it staff? You know, we do have to take those things into consideration. So intervening in different settings, you may have already come across patients that have become angry and aggressive in a general hospital setting, and usually that's because they have a loss of control or autonomy. And so some of the feelings that kind of lead up to that are feeling embarrassed or frightened, maybe guilty, ignored, inadequate, out of control of the situation. Maybe they just don't have any idea of what their next step is going to be, and that may provoke anger in them. We may experience patients that actually have healthy coping skills but are completely overwhelmed, and we'll see anger and aggression with that. And then I think we've already talked about most of these other issues here. Okay, so audience response question here. A violent patient is restrained. What's our first priority? Do we debrief the patient? Do we ensure the patient's safety? Do we administer a sedating medication? Or do we obtain an order from the healthcare provider? So remember, our first priority, you can kind of never go wrong with choosing what's going to be safest for your patient. So our first priority is going to be ensuring the patient is safe. The second would probably be an order from the healthcare provider. Okay, last question here. Which patient behavior is a criterion for mechanical restraints? So is it a patient that's screaming profanities? One that is assaulting a staff person? One that is refusing a medication dose? Or one that's throwing a pillow at another patient? The correct answer here is a patient that is assaulting a staff person. This is a person that is at risk for harming somebody else. So that would be our priority person here to possibly do a mechanical restraint on if we have tried all other means of de-escalating the situation. If you guys have any questions on chapter 27 or if some of this didn't answer your learning objectives, just send me an email and we can discuss those in that manner. Thank you.